Well, hello, everyone. It is great to be back with you here at SADS Facebook Live Land. I missed you guys last week. My boss and CEO of the Sudden Arrhythmia Death Syndrome Foundation, the SADS Foundation, Alice Laura, gave me the day off last Friday. And it was a good Friday. And I hope you had a good Friday as well. And for those of you who celebrated Easter blessings and Easter blessings to you. It was a great week, and I'll show you a reason why. You want to see? Here's one of the reasons why my Easter weekend was so amazing. So I got to spend it with Jaden, and it was a great weekend off. So thanks to Alice for giving me the break, but I missed you, and I'm excited to be back with you for SADS Facebook Live number 58. And today is your day with your questions. And before we tackle your questions, come on board, start putting your questions, make them pithy. The word of the day, short and sweet, so I can get to them and get to as many of them as we can. We are still in COVID-19 pandemic land. Things are getting brighter, don't you think? But it is impressive. I looked at things up this morning worldwide, 134 million cases, almost 3 million deaths in the world from SARS-CoV-2. In the United States, we crossed 31 million cases. We're approaching, in not too long, 10% of the United States population will have had SARS-CoV-2, 560,000 plus deaths. Yesterday, we accrued 80,000 cases. So I hope this isn't something, but here, that's where we're at. See that over there, over here, a little spike again. People have been talking about a fourth surge. I hope we're not going to have that. Stay doing all of the right things. Mask up, at least inside. Good news, guess what? Here at Mayo Clinic, we got to drop the eyeglass covering, so we don't have to wear those. So we're getting closer. I can't wait until the masks are off and I can see all of my patients' face. But for now, we're still masked up indoors. Did you see the good news? Less than 0.1% of all COVID cases seem to be contracted from the outdoors. So I don't know about you, but I do not wear my mask when I'm rollerblading my dog, Bella, and some of you, I think, Bree, yes, you're there. Rollerblade my dog, or outdoors, walking the golf course outdoors, I'm not having the mask on. For me, indoors, yes. Wash your hands, do it. You remember, alcohol kills the virus. When it's your turn to get the vaccine, get the vaccine. I got mine back in January. Mine was the Pfizer. That's only because that's what Mayo Clinic was dispensing at that time. I like the Pfizer vaccine a lot. I like the Moderna vaccine a lot. Which vaccine should you get? Yes, the one that's available to you. Remember, we're now over a year in the pandemic. I still do not have a single case, not one, of any of my genetic heart disease patients' families where the virus resulting in COVID-19 has triggered their long QT, or triggered their CPVT, or triggered their Brugada. So this virus does not look to be dangerous at all to your underlying heart disease. That's good. The therapies, if you have COVID-19 and it's more than just losing taste and smell and you need treatment, all of the current treatments are heart safe, QT safe. The older treatments, which I hope nobody's really doing anymore, hydroxychloroquine and azithromycin, are QT dangerous in somebody with long QT syndrome. The vaccines are heart safe, QT safe, Brugada safe. Only minor issue is if the vaccine results in temporary fever, lower your fever. And still, we have not had a single vaccinated patient with long QT, CPVT, Brugada, etc., where the fever that may or may not occur has then triggered their heart issue. I see Brianne got her first dose of Moderna yesterday. Yay. Yeah, my arm was a little sore too. Sneak preview, the second one, 26 days later, is a little bit worse, not a lot, but I felt unwell for a day after my second Pfizer. I did go to work, so you probably will too. So that's our Moderna. That's our COVID-19 update. Oh, the other update since I was gone, I got to show you this, and then I'll look at your questions. I showed you my son. Here's one. A shout out and a congrats to Coach Drew and Baylor University. National champions, Division I men's basketball Monday night. Amazing game, beat Gonzaga. And as you know, I'm a little biased because my son Jens is a Baylor Bear. So sick 'em Bears. And congrats to Coach Drew and the men, his staff, and the players. I met many of the student athletes, amazing men. So congrats to them. All right, here we go. I'm going to the top, see what questions. Oh, thanks, Summer. I agree. And then I'm sorry so much for you with the loss of your baby from type 14 long QT. And we just got the genetic test result. Your husband has type 8. Is it possible? So there, I think what you'll need to do, and I would love for you to reach out to our team at the SADS Foundation, get the genetic test reports for them to review. I'm happy to review it. There's a lot of confusion on some of the minor genes. In fact, many of you know that you're LQT1, 2, or 3 because those are the 3 most common. After that, it gets harder to know what is type 14, which gene is responsible. I know because my team discovered that genetic subtype, but we probably need to know a little bit more detail as if that was a calmodulin mutation and what kind and what is it that they found in your husband's sample in the calcium channel gene, which is responsible for type 8. So I'm so sorry about the loss of your baby, and let us try to help you. Guten Tag from Germany and Erica. Let's see what questions I'm scrolling through. Is it dangerous to our Timothy children? So Summer, that's a great question. As you know, Timothy syndrome is a really rare genetic heart disease. It probably comprises about 1 in a million people have Timothy syndrome. Timothy syndrome is a result of mutations in the CACNA1C encoded L-type calcium channel. When it results in the whole syndrome of not just the heart, but other issues in other organs, endocrine organs, and so forth, it's Timothy syndrome. Sometimes it's just the heart, nothing else, and then it's LQT8. And as far as we know, we haven't seen any signal of concern for the vaccine in Timothy kids or Timothy individuals, but you can imagine that the numbers are really small because we're not even yet vaccinating children. The vaccines are for age 16 and up so far. In the United States, rolling out vaccination for 16-year-olds and older will probably start mid-April, early May. So we don't really truly know, but I don't see any pre-knowledge basis for why it would be of concern. And Mr. or Ms. Adila, just hang in there. We've been a little bit overwhelmed at SADS Foundation, so email again and they'll start working with that. And Barbara's sharing an FYI about diarrhea. It could be severe and a side effect with Pfizer. I'm not sure it's unique to Pfizer. I think everybody can potentially have that reaction. That reaction is actually pretty uncommon. But whatever the reason for diarrhea, remember that if a person is having significant diarrhea that could be resulting in dehydration and loss of electrolytes, especially potassium, that low body potassium called hypokalemia can be QT aggravating. And that's mainly for long QT, not much of an issue for the other genetic heart conditions. So like all of us, if we had significant diarrhea, we should be staying replenished. Long QT people should be a little bit more keenly aware of the importance in doing that. So thank you for pointing that out, Barbara. Debbie's asking who's eligible for genetic testing and for the son who passed with SADS and a non-specific diagnosis. So Debbie, I'm so sorry for your loss. In our program here and throughout the world now, we would be putting all of the initial focus on your son in terms of what did the autopsy reveal, what were the circumstances, what does the genetic test in your son who passed away, what does that show, and then go from there. Meanwhile, we would also focus on his siblings and his parents and do some standard cardiac tests in the living to see if anybody shows any signals of genetic heart disease. To that end, there's going to be a great webinar coming up, I think Tuesday, the 29th of April at noon Central Time, a webinar on the evaluation of sudden arrhythmic death syndrome or unexplained sudden death in the young with Elijah Bear from the United Kingdom and Arthur Wilde from Amsterdam, two of my dearest friends, providing that. So check in on that. You can check in at SADS to find the exact details. Don't miss that. You'll love that program. Turmeric, Brienne, turmeric, and is it safe for long QT? I don't think there's any concern with that, but that's a great question. We are going to try to do a program on supplements. There's a lot of stuff out there about supplements. There's a lot of supplements, and trying to point out how do you try to decide whether that supplement, whether it's an energy drink or a pre-workout formula, whether that is heart friendly, and we'll try to get that program up and running and for one of the upcoming ones. So not a silly question, great question. And Tammy's just sharing that one that Kevin got the Moderna vaccine, did well, no migraine with it, so that's great. Rebecca, I have no idea what they mean by that designation of the gene mutation. I think you should work with your genetic counselor to know what is that. That designation is a designation that would suggest that the amino acid did not change for whatever gene that was. So you really need to work with the health professional and his or her genetic counselor who ordered your genetic test to get it translated for you. Greetings from Ireland. We still at Mayo Clinic have not been given the green light for international travel yet. So I don't get to go to Dublin yet, but I can't wait to get back there. It's coming. We now have freedom at Mayo Clinic for domestic travel. So things are starting to train. Domestic travel got banned for us at Mayo Clinic a year ago, March 2020, and the ban just got lifted 2 weeks ago. So hang in there, everybody. Yeah, the 10%, I'm not sure I buy it. So whatever in terms of the frequency of diarrhea, I think diarrhea is a common side effect of almost everything we do. And that's probably because our bowel habits change. Bottom line, if you're having significant diarrhea, stay hydrated and otherwise don't worry about it. Eve, hello, Eve. Do the COVID monoclonal antibodies cause prolonged QT? Can a person? Absolutely. So I love that question, Eve. Every current COVID-19 therapy minus azithromycin and hydroxychloroquine, which I hardly count as current anymore because really nobody should be using those two medicines. So the current contemporary established therapies for COVID-19, including the monoclonal antibodies, are QT safe. Remdesivir is QT safe. The vaccines are QT safe. The steroid, dexamethasone, is QT safe. So yes, if you needed it because your SARS-CoV-2 virus was a little bit more, you can take it. Now that brings me to another point, Eve. We're going to try to get, yes, for the third time, Dr. Stacy Rizza. She has the record for my programs with her as the highest viewed of our programs. And so we had her 3 months ago, but a lot has happened, hasn't it? And people are wondering now that the vaccination program is getting rolled out, should I get it? Which one? What's the business about the blood clots? Not that big of a deal, but what's the business with the AstraZeneca vaccine? So I'm going to try to get my neighbor, Dr. Stacy Rizza, back. So thanks for that question, Eve. So Emily's talking about a variant of uncertain significance that I downgraded, which means I probably felt that the evidence was weak and it didn't deserve to be called ambiguous or uncertain. It should be demoted to likely benign. That's what downgraded means. The cardiologist still thinks that you might have asymptomatic Brugada. If we find other family members with a pattern, couldn't theirs just be from the same mutation that is benign? Well, that's a really great point. So really it is detective work. So if your cardiologist thinks you have an asymptomatic but type 1 Brugada ECG pattern, regardless of your genetic test result, all first-degree relatives, siblings, children, parents should get the ECG done. If one or more of your family members shows that same ECG pattern that we call type 1 Brugada ECG, that's not just two family members having a Brugada pattern. That's Brugada syndrome, and the genetic marker doesn't have anything to do with it. Now, having said that, would I test that person who has that positive ECG to see if they have that VUS that I downgraded? Because what if I'm wrong? And if there's concordance, then that might reopen the case and have us look at the strength of evidence again. And Summer, you are most welcome. It's been my pleasure. Like I said, I missed you guys last week. Wendy's question for your granddaughter, isn't it amazing to be a grandparent? I agree. Was positive for the LQT2. Her EKG shows the prolonged segment. You don't know what the number is. She's symptom-free. I expect her to be. She has an appointment to discuss putting her on beta blockers. Do you recommend starting them this early? In general, Wendy, great question for your granddaughter. It really depends on that ECG. How long is that QTC? Now, having said that, there are programs throughout the world where the positive genetic test alone, no matter what the ECG shows, would cause them to start your granddaughter on the twice-a-day liquid beta blocker Nadolol or the 3 times a day liquid beta blocker propranolol. And our program has changed from that strategy about a decade ago, where we have started to ask the question, do we have to start everyone on a beta blocker the moment they're born when their genetic test comes back positive? And in our program, the answer has been no, we don't, in very carefully selected individuals, like baby girls, where their intrinsic risk before puberty is much lower. So if it's a baby girl and the QTC is hardly impressive, we might watch and wait. It all depends on what do you all think about that as a family. Is that anxiety provoking, anxiety relieving? It's complicated a bit, but most places would just start your granddaughter on the beta blocker. Some places are starting to ask the question, maybe we can monitor them if we think that their expressivity of their mutation in their body is really, really weak. So more to follow on that. We're going to learn more over the years about this idea of what we call intentional non-therapy with preventative measures only. Wonderful question. And Allie, I'm so sorry about your son, even though it's been now coming on 13 years since your son's death. I bet you can take yourself back to as if it occurred yesterday. So thanks for sharing that and thinking of you. Sherry's wondering what makes type 3 long QT syndrome so different from type 1 and 2. Is it that there's less studies on type 3? My son EP has mentioned, well, he's type 3 a few times. It's a good reminder that there are 3 major long QT genetic subtypes. So for you all there who are LQT1, that's the most common kind. About 35% to 40% of all long QT families are type 1. Then about 25 to 35% are type 2. And then the third most common, conveniently numbered, I don't think we designed it quite that way, are type 3. So LQT3 families represent about 5 to 10% of all long QT syndrome. We actually know a lot about LQT3. One of my previous guests and one of my dearest friends, I mentioned his name, Dr. Arthur Wilda, led one of the world's largest studies on LQT3. We recently published an experience of LQT3 starting in infancy. So we know a lot about it. It's very different from LQT1 and 2. LQT1 and 2 are due to mutations in potassium channels. LQT3 is due to mutations in a sodium channel. We know that beta blockers work in LQT3, no doubt, but they may not work as well as in LQT1 and LQT2, where the beta blockers work great and best in type 1 long QT syndrome. There is a medicine that works well in many LQT3 individuals, and it's called mixilotine. I like that medicine a lot for certain LQT3 patients. So we know a lot about LQT3. We think about it differently, but it's not lack of knowledge. We know a lot about type 3 long QT syndrome. SADS will give you information, Debbie, on when Elijah Bear and Arthur Wilda, but if I remember, that's questionable, but if I remember, it's a SADS webinar on Tuesday, April 29 at noon Central Standard Time. And then we had a question. Oh, good. We're on a good pace here, but they asked a long question here, so I have to look over here. But it's a great one. Develop prolonged QTC post-COVID. My cardiologist has discharged me after the test with a QTC of 498 on a low dose of beta blocker or a beta blocker. Still on 30% function level. I'm concerned that when my physical activity increases, so will my QTC rate. I don't want to risk going into VT. I'm a 52-year-old woman in the UK. So I would say a couple things there. We know now that the virus itself, the SARS-CoV-2 virus, in some people can infect the heart muscle cells. We've shown in the laboratory that when we expose re-engineered heart cells directly to the virus or to the spike protein, and we measure the QT interval of those heart cells, it's really not the QT, but you know what I mean, we can show that the virus itself can lengthen the QT interval in the dish. So we would think that that might mean that long QT people could be at greater risk of virus-mediated QT prolongation that then makes their long QT worse. The beauty of this thing is that even though that looks to be true in the dish, the whole human being is so much more resilient than the dish, than the cells in isolation, such that we seldom see, almost never, a virus COVID-19 triggered long QT spell. So yes, your QT might be transiently longer if it's measured correctly. I would call that an if. I'd like to see that for myself, but let's assume it's a true measurement. That QTC value, it should shorten in time. The respect I would give that 498 milliseconds is during this transient lengthening of your QT, I would make sure that nobody gets to prescribe you a medicine that's on the QT drugs hit list. Never forget that list, www.crediblemeds.org, and make sure that you do a QT safety check if anybody prescribes you anything, because you don't want to create a perfect storm where another QT agitator gets added to the mix. Otherwise, I think everything's going to be just fine. I think the 30% function, obviously you're going to have to see what impact that has had on your heart muscle strength, and your QT may be longer than what it was, more because of the weakening of the muscle than of the virus on the QT itself, because we know that people with a weaker pump their QT numbers can get a little bit longer. Erica's asking, what does type 2 Brugada mean? It actually means nothing. So that ECG pattern is a non-specific description of the ST segments. And that pattern, that type 2 pattern, only matters if it converts to a more specific and diagnostic type 1 Brugada pattern when you either move the leads up the chest and do the ECG again, and then it converted to the type 1 pattern, or you gave them a drug, Ajmaline in Europe or procainamide in the United States, and that drug made it change to the type 1 pattern. Otherwise, the type 2 is, forget about it. It's as we say, a nothing burger. You don't, nothing in there. You don't have to worry about it. That was a great question. And I see that the SADS, oh, wow, I got a little bit behind. And I see 15 minutes on our counter. I have missed this. If you want us to do questions and answers again, or what frequency, would you give a shout out to the team at the SADS Foundation and let them know whether you benefit from this monthly, weekly, daily? That won't happen. But what kind of frequency would you like to have this? We're working on the program for the rest of April. In terms of other people, we've got one coming up end of April focused on ARVC. That's going to be a good one, and so forth. But help us shape what your needs are and what kind of content you want. I love these question and answers. You stimulate the daylights out of me, and usually it results in a new project. So it creates work for my research team and hopefully a new discovery that will matter and help you all out. Dana, oh, thanks. That's sweet. And give Marco, Dr. Perez, a hello from me as well. Great, great guy. Greg sharing that his parents and siblings are all negative for an SCN5A mutation, but that he and his 2.5-year-old daughter have it, and that you're waiting for your infant son's result, and that you had a Brugada VT storm 5 years ago, but have had a great result since your ablation. Great. Is it common for multiple members of a family to experience symptoms in Brugada syndrome? I love that question, Greg. If the information is correct about your family, what this means in all likelihood is that your Brugada associated sodium channel mutation started new in you. Mom's egg was clean, dad's sperm was clean, voila, after the fact, lightning bolt, and the mutation occurred spontaneously, de novo, after conception in you. But once it's in you, it's now in half of your sperm. And so each child you create, your daughter had a 50-50 chance, your son, flip a coin, will have a 50-50 chance of inheriting it. Importantly, what happened to you so far 5 years ago has zero forecast value for how it will behave in your daughter, and if your son's positive, in your son. Meaning every owner of the mutation is determining its behavior, its expressivity in them. So I would not be thinking that your daughter is heading towards a bad situation some point in time because of what happened to you 5 years ago. It may be nothing in your daughter forever. It may be something. Your doctors will have to monitor closely to see how is it showing itself in her body, and hopefully your son will test negative. No, I'll have to copy Dana's and send that to my family. I appreciate that kind words. So Nicole says, oh, I see, good one. See, this is what's so important, isn't it, about having our genetic counselors on your team and people who will help decode your genetic test report. Nicole's sharing that she has this particular variant with a +1 sign in the KCNH2, but positive for LQT1 and LQT7. Yeah, and I see, I'm not sure which type of long QT I have. Well, I share your question, Nicole, because I think whoever has handled your situation so far has not done what they need to do to communicate the result accurately and precisely to you. That first genetic variant, for example, is predictably a splice site variant in the KCNH2 encoded KV11.1 potassium channel. Translation, LQT2. So I'm not sure what they're referring to by LQT1 in the first place and LQT7 in the second place. So it's confusing. If you're confused, you have good reason. That report is confusing. And if you're not getting clarity, I'd be delighted to help. Obviously, I'd be delighted to see you. Half of my practice is video medicine. I had a video consult with a family way far away yesterday. So for those who can come on campus, I'm delighted to see half of your face. For those of you who we do the consult by video, I get to see all of your face. But bottom line is, I'd like to help get clarification for you, Nicole, because it's not been communicated to you well. And we need to do a better job of communicating, don't we? I couldn't help. I was so upset 2 days ago with a family, beautiful family. I wasn't upset with the family. I was upset with the message that the family has been under for the first 10 years of their daughter's life. That family's heart rhythm specialist told the family, according to the mother, quote, your daughter will not live very long. Block out all noises. Don't let her walk up the stairs, and learn CPR because you're going to have to use it. Wrong, 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 wrong. You can imagine the kind of stranglehold that has on a mother and father emotionally. And so we, our community, and that's what we're doing at the SADS Foundation, we're trying to make the home where families get seen by those heart specialists to be a better home, to be a more competent home. I can't tell you, and you probably know, all of the things that you've been told over your years that have been flat out wrong or bordering on mean-spirited and just ignorant. Like telling my long QT families, telling the young woman, the teenage girl, don't ever become a mom. You won't ever become a mom. Wrong. Almost all of my long QT, all of my patients with almost every well, the women, men can't have babies. I learned that. But the females, yes, 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 you can become a mom. And if that's something you're wanting to do, it'll be amazing. Half of the children might have long QT or CPVT or Brugada. Half will not. We know how to treat these diseases. We have to do better in what we say, how we say it to our family. Sorry, I'm still a little bit revved by the destruction and the destructive nature of those incompetent words that were communicated to that beautiful family. And I can't tell you the freedom just before my eyes that she's hearing when I told her, I'm going to be seeing your daughter for about the next 15 years before they put me out to pasture. And then it will be somebody else's turn, as in saying, we're going to live a long time with your long QT. And there's going to be noises that will come. Let them come. We got this treated. There are going to be stairs to climb. Climb the stairs. Live. And the mother was just, it was just an unbelievable a moment. And I wish I would have been able to have intercepted the incompetence 10 years sooner for that family. Anyway, so Nicole, I want to help you as well. Michelle's asking a really good question. Is it important to know whether you're type 1, type 2, type 3 long QT? My daughters and I are all considered borderline, but no specific type was ever mentioned. We're all asymptomatic, but we're taking a beta blocker as a precaution. Yes, 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 you need to know which type. I am guessing that because you've been called borderline, which is an expression that I dislike, because it doesn't really tell us, do I have it or don't I have it? My view is, if somebody's going to call any family borderline long QT, they must do genetic testing. Because if that genetic test comes back negative, that negative genetic test by itself rules out 80% of all long QT. So yes, you still could have long QT and a negative genetic test, but if you are a negative genetic test individual, that evidence must be really strong, not weak, not borderline. And so I'm guessing that your team has never done the genetic test and are just calling you borderline and treating you anyway. Is that a big deal? Well, beta blockers are one of the safest medicines we have, but it's still medicine. And I can tell you a lot of patients, the beta blockers has been a big deal, changed their life. And so I like that beta blocker. I don't use it very often, but I like it. But more importantly, I don't think your diagnostic evaluation is tight enough. If I'm going to call somebody long QT, or you might have long QT, or I'm going to treat you in case you have long QT, you better get the long QT genetic test, because I really want to know, do you have it? Which genetic type do you have? 1, 2, or 3? Because if, depending on that answer, I'm going to treat you in a LQT1 strategy, or an LQT2 strategy, or an LQT3 strategy. In other words, one size does not fit all, and I have a distinct and definite strategy for each of the genetic subtypes. And so Michelle added while I was answering that there's been no gene detected. So that would make me do the big timeout and say, if I'm going to still call you and your children, your daughters, long QT, do I really buy that? Do I really believe that? Maybe the answer is yes. And if so, then we would do novel genetic exploration to find yours. But I think a negative genetic test in somebody called borderline mandates a reanalysis of the strength of the evidence and a willingness to potentially pick up the proverbial flag off of the ground and say, after further review, there's insufficient evidence for this penalty. That's the kind of work that we have to do. Yeah, Nicole, I'm so sorry your cardiologist told you that, and I'm so glad you did not listen if that means that you do have kids. And Sherry, and I'm going to give Sherry, it looks like I made it to the list, and I made it to the bottom with 3 minutes to spare. Sherry, I give you the final one. Your 10-year-old has type 3, so that's the sodium channel version of long QT, and is on Nadolol at 40 milligrams. Should I ask the EP about Mexilotine? Not necessarily. I have many long QT3 patients where I'm treating with only the beta blocker, and I like Nadolol for long QT syndrome. I have a little bias. I tend to like propranolol better if it's LQT3. LQT1 and 2, I like Nadolol the best, but that doesn't mean that I am right. It's just what I do in our program here at Mayo Clinic. But if he's doing well and thriving and the QT is not that impressive and he's symptom-free, asymptomatic, no, I'd probably stay the course. If he's had events and if his QTC is above 500, I would start asking the question, should I, as the long QT specialist, try to do something to get that QT number under 500? And that something in LQT3 might be Mexilotine. And so it's worth talking about. It's worth asking and inquiring about. It's not worth mandating because your son's LQT3 risk category may be super low. I love that question. And I agree with the SADS Foundation with the wow. It was great to hear from you all today. I loved it. I hope you have enjoyed it. And thank you for your incredible questions. For those of you who your story is in tragedy and you're still very much in the midst of the profound grief, I'm so sorry. I'm not trying to pass over the heaviness of what the toll that that death has taken in your family's life. And so I think of you. I wish nothing but the best for all of you who are joining us. Get your friends. For those who are benefiting, tell people about our program. If you want to partner with us in a financially tangible way, hit that donate now button online on www.sads.org, or if you like the mindset of www.stopsads.org. Either way, it gets you to us. You can hit the donate now button in the top right corner and partner with us and help us make a difference. I can't wait to be with you again next Friday. We don't have the program in place yet. Whatever it is, you're not going to want to miss it. Until then, remember, faith over fear. I love that. Thank you for that shirt. It's going to stay up there. And all the best to all of you, and have a wonderful weekend. And I look forward to being back with you again next Friday. Same time, same place. Till then, bye, everyone.